Hello and welcome to BoneUP, the podcast all about bones, how we make them, why we break them, and if we fully understand them. I'm David Armstrong.
Hi, and I'm Richie Abel. And over this series, we're going to be exploring osteoporosis, bones, what we know and what we're yet to discover. And we hope you will join us on the journey.
So for anyone keen to learn more about our infrastructure of calcified collagen, this is BoneUP. Hello and welcome to another edition of BoneUP Live. We're here in Innsbruck in the Tyrol region of Austria to attend the European Calcified Tissue Society Congress. Richie, excited?
Oh, very excited. This year at BoneUP Live 2025, the ECTS Congress have been really kind to us and given us our own room. We're in the Alborg on floor 3. We've got beautiful views of the Alps out of the window. Listeners, I wish you could see this. Cloud-covered Alps stretching back nice and green into the distance. It's absolutely beautiful here.
Yeah, it really is. It really is very impressive. Lovely place to have a conference and lovely place to talk to people about the latest news in clinical and basic science research in the world of bone. And we've got our famous mugs here with us as well, Richie.
We have listeners, the guests are really keen to get their hands on a mug. They're becoming a highly sought-after item in the bone world.
We hope we'll bring you a bit of a flavour of what's going on at the conference here as we interview some high-profile speakers and some people towards the start of their career, just presenting their work or their papers here at the conference.
David, last night we went to the opening ceremony of the conference and we heard a really great debate about the treatment of patients with diabetes and whether or not patients with diabetes should receive a DEXA scan as part of their standard care. What did you make of the debate last night?
I thought it was a useful debate. It was sort of couched in terms of a representative from the ECTS speaking against a representative from the American Society, although in effect, actually, one of the speakers was from Italy and one from Australia. But it was very useful, and regardless of the outcome of the debate, it raised issues about bone quality as well as just bone quantity, about how DEXA can be useful, but how fracture risk is a lot more than DEXA, and how we should be looking outside just our sort of narrow vision on bones to all the other groups of people, for example, people with type 2 diabetes, who we know have higher fracture risk, but we may not be certain just how best to assess those patients at the moment. So yeah, it was an interesting start to the conference.
I feel it set a very good scene for the conference. There's a lot of research still to do to improve patient care, and we've got to get all of the basic scientists and the clinicians together. And it was nice to see everybody coming together for the debate last night. And hopefully, listeners, we're going to bring you a flavour of that debate over the coming days. So we better get on to our first guest. Listeners, we're very pleased to announce our first guest of ECTS 2025, Giovanni Adami. Giovanni's a rheumatologist and MD from the University of Verona. Welcome.
Thank you. Thanks for having me. It's a great pleasure.
We're delighted to have you here. There's so many things we could talk to you about. You have so much on your CV. I tend to get into the very clinical questions, so I'm going to ask you immediately about a paper you published last year, I think in JBMR Plus, which looked at the interesting and relevant question that if you're a patient who is receiving denosumab injections and you have a further fracture, what do we do at that point? And you looked at adding romosozumab to denosumab.
Yeah, correct.
So what was the outcome from that?
Well, that paper we published in 2024 was focused on the 6 months results of an observational study that is still ongoing, and we are going to publish the 12 months results hopefully very soon. So basically the underlying question is what to do when you fail denosumab. So failing denosumab means that you have a very high risk patient and you want to do more for that patient, and so you might have a very low BND or not reaching the threshold for being happy with their BND or having a new fractures. And the problem with that is that the conventional sequence treatment or whatever guidelines you are looking at suggest to switch to an anabolic, which make perfectly sense for bisphosphonates, but it's not really the most advisable strategy for a patient on denosumab, because we fear the rebound of turnover and multiple vertebral fracture after denosumab discontinuation. So the problem here is that it would be advisable to discontinue whatsoever denosumab independently for what you are going to give the patient after that. So one can think, no, I can switch to zoledronic acid and then consolidate and then give an anabolic. Yeah, that might be reasonable, but you're really looking for an imminent risk of fracture, so you want to give the best treatment immediately to that patient.
That
because
will work
that,
most quickly.
Yeah, to work quickly. Yeah, that's exactly the point. So maybe combining the treatment might be the idea. And the working hypothesis for our study was that maybe we can combine teriparatide or abaloparatide in these patients, but we do not have the evidence for ongoing patients with denosumab, so with a closed remodeling surface, and add on top of that teriparatide. So it might not work properly as has been seen in the data study. So the working hypothesis was that maybe romosozumab, by leveraging on modeling, and so it might be more effective. And so we tested that.
Yeah.
And that was an observational study. So basically, we just enroll patients that need a combination treatment that was eventually find out to be reimbursed in Italy, because there's nothing that no contraindication in the label and no contraindication in the reimbursement criteria. So we combined the two treatments, and we found that there was an increase as compared to patients that continue denosumab.
So some of the patients just continued with the denosumab, and some you added romosozumab
Correct.
as well as the denosumab. So as well as getting their 6-monthly denosumab, they were getting romosozumab
On
once a
top of
month
that.
as well. And in those group of patients, because we always think of the spine and the hip. So what happened at the spine?
That was something that we would not really have an explanation for that. Maybe it's just the follow-up times. We will have the results of the 12 months, or maybe it's just the sample size problems. But what we found was that in the combination group, the lumbar spine went very well. It increased more than the denosumab alone. You might have said.
So if you added romosozumab, your
the spine
bone
went
density
up.
went up. Good.
Yes, by 7% in 6 months, which is
Good.
remarkable.
Absolutely. Yeah.
But the total lip and femoral neck did not perform as expected.
Okay.
So they stay quite stable over the 6 months. They don't go down.
They don't go down. That's important, because that was a concern. If you added teriparatide, if you switched from denosumab to teriparatide, bone density might go down.
Might go down,
It
yeah.
didn't go down, but it didn't go up either with the romosozumab. Is that right?
It didn't go up either. I can tell you that we have a poster here. We did the presentation at the WTO, and we are preparing the paper that for the 12 months it goes a little bit up.
Okay.
So it is
Breaking news, folks.
So it's a good results and confirms what we would have expected. The question now is the switching from denosumab to romosozumab as effective as doing the combination? Well, actually, we did not do that, because we feared the rebound, because most of the patients that we had were on very long-term denosumab. So basically, the risk for rebound vertebral fracture was very high.
Yeah.
But there is a study, if you look in the literature, by Hong, which published the switching from denosumab to romo. But again, in that study, the mean treatment duration with denosumab was 2 years. So it's not that long. And they found actually a rebound. They found that CTX is going very, very high after the introduction of Romo. So there's still an open question, I think. And randomized control trial is highly needed here.
Yeah, and I think this highlights something we may talk more about probably at the conference, how while some people are very focused on head-to-head studies between drugs to show which is better now, most patients are more interested in the long-term sequence because they will possibly be on most of these stronger drugs, and we just want to know how do we combine them, when do we stop them, rather than just head-to-head studies. So I think it's very relevant, and probably you would say then for my patient who I've been giving denosumab injections to for 5 years, they've had a new vertebral fracture, there probably is evidence from what you suggest that switching to romosozumab would be preferable for a good number of those patients from your evidence than just continuing with the denosumab.
Well, yeah, combining romosozumab.
That's what I mean.
Yeah.
Sorry, combining
might be the right option. I mean that is quite consistent throughout the medicine.
Yeah.
That's combining two drugs is better than using one.
Yeah.
And that has been shown by the data study. That was naive patients. There are many convincing studies in hypertension and cardiovascular risk, which we combine the drugs.
Absolutely.
And this the rationale behind combining an antibiotic with the bone anabolic, and in this case, Romo is a very strong bone anabolic. Don't forget about that. Well, we have some clinical evidence at least.
I suppose we should say this is all bone mineral density evidence. It's not fractures. Obviously, we're talking about at 6 months.
Absolutely.
But nevertheless, we're reasonable to presume that if your bone mineral density goes up, it's going to be.
That's very reasonable. Yeah.
No, that's very interesting. We wait for the 12-month data with excitement.
Giovanni, you've got another talk at the conference. Our regular listeners will know that romosozumab treatment lasts for 12 months because bone is homeostatic, and after the treatment is given, bone will return back to its normal physiology after a while. And you've been perhaps investigating some of the reasons why that might happen?
Well, yeah, thanks for asking. Yeah, basically, we did a prospective study in which we observed in naive patients with no treatment at all, and we started Romo. We want to investigate what are the factors that are associated with the waning of the romosozumab efficacy over the time. And so we explore what could be the most reasonable thing, which is an increase in the Wnt inhibitors other than sclerostin. And so we explored the mostly studied and probably the most important Wnt inhibitor, which is DKK1. And this is again, what's surprising to look at the literature and finding that nobody has published anything on that. So I strongly suspect that the companies has had that type of data, but we don't know actually. We don't have the data. We don't have the publication for that. So we just very simply, very easily measure the DKK1 over the time. And not surprisingly, we find out that was increasing. And that increase was correlated beyond month 3 of treatment to the decrease in P1NP. So P1NP peaked, DKK1 stays stable, and then after the peak in P1NP, we found an increase, very linear increase in DKK1 over the time. So our speculation is that, well, that's not surprising. That was somehow expected. There's a negative feedback of the bone that tends to go back to the normality, and was not expected based on also on studies in sclerostosis. Sclerostosis patient has been shown to have DKK1 higher than normal, and that might be a protective mechanism that avoid an excessive bone formation that will kill the patient. So eventually, if you look at the natural history of sclerostosis, they have a plateau in bone mineral density. That one of the possible reasons, not the only, I agree, but one of the possible reasons is that they have an increase in DKK1 serum levels. So it might be a protective effect. And what is interesting to know from the literature again is that if you combine anti-sclerostin and anti-DKK1, you have a very extremely potent drug. And there's the phase 1 study from the dual inhibitor, very recently presented at ASBMR and IOF. And so they showed an increase in bone mineral density, which was absolutely stunning, skyrocketing up BMD. But the problem might be safety. You know, there are some preclinical studies showing, especially in monkeys, that the dual inhibition might result in the thickening of the cranial bones, and so might be harmful. We really don't know. We have some reassuring phase 1 data from that study that is safety is okay, but we really don't know. It might be that the increase in DKK1 is some kind of protection.
Yeah, which is something you see in sclerostosis, the thickening of the skull bone as well. But perhaps in a few years we'll be talking about a DKK1 antibody here at these meetings.
Hopefully, yeah.
Our regular listeners who tuned into ECTS last year, remember you heard it here first when we spoke to Roland Barron. He told us that there was a study ongoing.
Yeah.
And it's great to hear the results are out now. So if I follow this right then, basically what you're saying is the osteocytes then, the bone cells, they release sclerostin and DKK1, which both suppress bone mass. And if you suppress the sclerostin with romosozumab to relieve the inhibition on Wnt and increase bone mass, the osteocytes then come back by releasing the DKK1 to rebalance the system.
Well, the main source of DKK1 is probably not osteocytes. It's probably released by many, many other cells. One of that is the osteoblasts. Other that are secreting are from the macrophage lineage, so T cells and other immune cells. So it's not really clear where does this DKK1 come from. But what is evident is that it plays a major role. Because if you inhibit that, and what is even more interesting is that DKK1 is a very crucial mediator of bone loss in multiple myeloma and very erosive disease like rheumatoid arthritis. So that's very fascinating, thinking of, Romo might be very efficacious in multiple myeloma, but who knows what happened on the DKK1 side? Who knows, the pros and cons and need to be studied.
Does that mean that maybe DKK1 antibodies could potentially be a treatment for rheumatoid arthritis as well?
Yeah, absolutely. That is the very next future, I think. There have been studies, phase 1 studies with oral DKK1 inhibitors in multiple myeloma. Yeah. That was a very promising drug for multiple myeloma. But unfortunately, the problem with DKK1 is, again, it's produced by many cells all over so it's ubiquitous. And you have a lot of cells producing, so the safety concern is always one of the big problem. Sclerostin, on the other side, is very tissue-specific. Yeah. It's just secreted by the osteocytes just in the bone, so it's more, let's say, safe.
Mm-hmm. Giovanni, you're one of the most active people at the ECTS conference. Every year you give lots of talks, and I see you running around everywhere. I was lucky enough to see your talk yesterday about artificial intelligence. And you gave a really fascinating talk about how AI might be able to improve fracture risk prediction. Would you tell our listeners about your research?
Well, how can we improve fracture risk prediction, and why it is important to improve fracture risk prediction? I mean, we have the DEXA. The problem with the DEXA is that it's not capturing fractures. It's very good instrument for patients that have osteoporosis. But for patients that fractures in the osteopenic levels, which are the vast majority of the women all over the world, well, you might misdiagnose those patients because they are at risk, actually, because they will fracture in the future, but they do not have osteoporosis from the classical densitometric definition and classification. So basically, we need something else, so we included the clinical criteria, that is the FRAX or other fracture risk assessment tool, but that makes a big problem. The big problem is that we need to balance the complexity of the fracture risk algorithm. So we really do not want a fracture risk algorithm that makes hundreds of variables inside of that, because it's not practical. It's not practicable. Yeah. It's very unfeasible in the clinical practice. On the other side, we need to have precision. And the problem with that is that the FRAX, it is improving our precision as compared to DEXA, but it's not as precise as we might desire. So the area under the curve, which is a metrics for performance of the classification accuracy of these algorithms is around 0.6, 0.7. It depends on the population. So it's not that good. We are missing a lot of patients. And that is where artificial intelligence might help a lot, because it can digest the complexity, and so you can put a lot of variables, and in terms of seconds, have your classification criteria and your classification of the patient, so at risk or not at risk, and what type of risk, and the precision improves substantially. So basically, there are many studies showing these, and they leverage on many features that we previously did not think were associated with fractures. So that's another very, very interesting point. Artificial intelligence is looking at patterns inside your variables, inside your data set, that you might never think of were associated with fractures. So that's a very important thing. I agree with you that sometimes we do not have an explanation, and physicians tend to be, very attracted to explanation, to biological rationale. So they really do want to see some flow chart. They do want to see what is actually increasing the risk in my patient, because I want to modify that risk factor. But then now we have some explanatory models, so explanatory artificial intelligence that are overcoming the black box which is inside it. So we might have answers even to that.
Yeah. It's fantastic to hear about such cutting-edge research in the bone world.
And as well as predicting fracture, can you see AI being able to give us an idea of how we would treat patients, in the sense of the sequence of drugs, or which patients may respond better to different drugs that we wouldn't necessarily see from our randomized control trials?
Absolutely, that is absolutely true, especially because you leverage on big data. And randomized control trial is a very homogeneous population, so you cannot really draw a conclusion on prediction of response in different population, because you don't have different populations inside the randomized control trial. It's very homogeneous, mostly healthy patients. And so basically the big data can include a lot of variables, and you can even predict response to treatment. So this is truly a precision medicine. So that type of patient might benefit to this treatment followed by that and that and that for the lifetime. And that is clearly the near future, and will avoid a lot of overtreatment, a lot of expenditures related to overtreatment, and so eventually improves the quality of care overall.
It's amazing to see you pushing forward on so many fronts, Giovanni. Thank you so much for coming to talk to us today.
Thanks. It was a real pleasure being here with you.
It's great to speak to you. Thank you.
Thank you.
Listeners, we're really pleased to introduce our next guest today. His name is Professor Claus-Christian Gluer. He's from the section of biomedical imaging in the Department of Radiology and Neuroradiology at the University of Kiel. Klaus, welcome.
Thank you, Richard and David. It's a great pleasure to be with you here.
It's very nice to meet you, and very nice to meet your wife as well, who I understand is a keen listener to the podcast.
We both are, actually. I think it's terrific what you've put on, and it's a great way of really broadening the awareness of osteoporosis and musculoskeletal.
Thank you. That's
Fantastic, thank
kind
you.
of you. There are so many things we could ask you about. One of the things that really impressed me with one of the talks you give here at the conference, right from the start of our podcast, we talked to people about estimating fracture risk and how it's much more than just doing a DEXA scan. We need to look at lots of things and put them together. And we introduced the audience to this concept of the FRAC score, which is an algorithm to help estimate fracture risk. But you told us about a new algorithm perhaps for fracture risk called Hive. Is that right? Tell us a little more about that and where it might fit in.
Yes. So, yes, we have developed a new algorithm, that you said, and the name is Hive, and this comes from hip fractures, HI, and vertebral fractures, VE. So this is right away one of the things that we do a little bit different from, for example, the FRAX or the Garvin or other risk calculators. So we focus on what we believe are the two most important fractures and also the most typical fractures for osteoporosis, particularly vertebral fractures. So to get on the one hand really the serious outcomes in the center of attention, and secondly also improve hopefully the ability to predict fractures and to identify patients at risk.
It was very interesting when we saw your talk yesterday. In the Hive algorithm, you calculate risk at 3 years, whereas some of the other risk assessments like FRAX calculated at 10 years. Why did you go for 3 years?
Yes, I think first of all, I'd like to emphasize that FRAX has done a fabulous job over the years. I mean, we need to appreciate that has been around now for more than a decade, and really brought across the concept of fracture risk and how important it is to make decisions about interventions. But we thought a long time ago, what could we do better? And we always felt when we talked to physicians, personally I'm a physicist, so you have to take all my words with a grain of salt. But when we talk to clinicians, they say this is very difficult to understand. When you think about your health, 3 years is already quite a distance, and 10 years is hard. Particularly, we quite often talk about very elderly people, and if you're 75, this is not the horizon that you are concerned about. There's another reason. It's easier to predict the risk when the time interval is shorter. So your ability to differentiate patients who should get treatment and not get treatment is facilitated because of stronger gradients of risk over the shorter interval. And that was part of the data that I showed here.
And of course now we have drugs, the osteoanabolic drugs, which work very quickly, and we're talking about fracture risk reduction within 1 or 2 years, whereas perhaps 10 or 15 years ago when it was bisphosphonates, the fracture risk reduction was over a much longer period. And where do you get the data from for calculating the outcomes then in Hive? Where did that come from?
Yes. So we of course have German guidelines on osteoporosis, and there's a very active group in Germany led by Friederike Thomasius. And so a couple of years back, we initiated a very thorough literature review. We looked in the end at more than 2,000 papers in the setting that talks about risk factors, etc., and had an external company grading the evidence of all of these papers, and then really picked from the literature the most relevant in terms of strength, in terms of prevalence, risk factors in the context of hip fracture prediction or vertebral fracture prediction.
And these were papers from around the world?
From around the world.
Using patients from around the world of different ethnicities, backgrounds.
Absolutely. Okay, because that is really one of the currently still underlying assumptions, that while we have different risks in different countries, the relative risks for a given risk factor is fairly similar.
The same against the background in that country. Yeah.
Exactly. So there may be in the future more refined models, but for the time being we consider this internationally established risk factors. So we did this careful literature review, and then of course we needed to identify the base risk in the population. And we started with the German population, of course, but let's say you would like to use Hive in the future in other countries, you would only to re-establish the base risk in that particular country. And the base risk that we established was based on more than 600,000 patients from an insurance company database, where we had lots of the risk factors, and we excluded all of the patients that had any known risk factors to get to an estimate of the population risk of a super healthy individual without risk factors. So that's our base risk, and then you multiply all the other risk factors on top of it to get to the individualized risk of that person.
And do you need a DEXA scan? Do you need your bone mineral density from a DEXA scan, or can you do it without that?
We can do it without. We start with the base risk. We multiply then the risk of the two strongest risk factors in that individual. So we really go for the concept of personalized medicine. We ask patients what kind of diseases, thinking of secondary osteoporosis, etc., do you have? So we identify per patient the two strongest risk factors in that patient. That gives us then, together with the base risk, the risk without BMD. And if we have BMD available, we currently use the femoral BMD at the total hip. And then we have a third component that we multiply the risk with, and then we get to the full model, including base risk, clinical risk factors, and BMD.
That's a really good explanation of how the model works. I really wanted to know how these fracture risk assessments work, and I think for patients who are listening, people who are thinking about doing this test, it's really good for everybody to know exactly how the test works. What kind of risk factors came up as being the most important risk factors for most patients?
Okay, so this literature review that I talked about resulted in 33 risk factors picked.
Okay.
So it's quite a list.
Quite a lot, yeah.
Yes, and of course, you always could simplify things by disregarding something, and each doctor may have patients that come from different disease areas. So from a rheumatologist, there may be different risk factors, most
Lots of
prevalent.
people on steroid or something.
Exactly, yeah. But then when you have very elderly people, the geriatrician would have more like the falls-related risk factors. So timed up and go, how long does it take? These kind of tests. And so the most important ones, you could say, okay, what are these the most prevalent ones in the population? Or are these the strongest risk factors?
Yeah.
So among the strongest risk factors really are, for example, having already vertebral fractures, and maybe having not only one, but two or three. And if we have radiographs, we could incorporate also the severity of those fractures. And Dennis Black has written a wonderful paper years back that the relative risk could range from anywhere from 2 to 10, depending on what the vertebral fracture status is. Then a previous hip fracture is very important. But then also we need to look at patients that haven't yet fractured. So there are important aspects like Parkinson's disease, for example, then glucocorticoid therapy, many more. Yeah.
That's really incredible. Not only that you're providing an opportunity for people to have really individualized, personalized care, but actually Hive fits into the care pathways that the patients are going through. Because I guess for clinicians in lots of different fields, you know, if bone medicine isn't your expertise, having fracture risk assessment tools which contain the kind of data and measurements that you're used to using, you're used to collecting from your patients, might make it a bit easier for you to use as well.
And can our patients go online and measure their own Hive score now, or we're not at that stage yet?
We're not at that stage
not at that
yet,
stage
but
yet.
it's exactly where I think the field needs to head, because obviously recording the 33 takes time, and time is precious.
Or can I go online and calculate it for my patient as well? But no, it's not freely available yet.
The point is that we have a group of 3 people who have developed this algorithm, and I'm leading that group. And then we've done this for the DVO, the umbrella organization of about 20 bone societies in Germany. So the DVO has this guideline group that does the osteoporosis guideline. And we have provided now this algorithm. We have tested it in certain populations, now here with a soft population. But in order to apply it in the clinical setting, you have to certify it as a medical product.
Yes,
and that's a very expensive complex process.
Doesn't it seem strange you have to certify it as a medical product? But you do, and that's only right, because
Absolutely.
if you're making important management decisions based on it, then it has to be properly certified and regulated.
Yes.
And when clinicians make the management decisions with the patient, does the Hive software help them to do that?
I definitely hope so. Having just talked about that it's not yet certified, the base version, the simplified version of the Hive algorithm is part of the guidelines of 2023 in tabular form. So currently what you would have to do is to use those tables. They are available in the net. And it's a fairly simple way of calculating yourself whether you are above or below certain intervention thresholds. So applying our Hive algorithm in Germany was connected to something that's not the algorithm, but it's the guidelines. And the guidelines state that you have now 3 levels of risk that the physician should be worried about. So if you have a 3% risk of hip-over-vertebral fractures, you should start considering. If you're below, then you're fine for some time. If you're above 5%, then it's modified to a very strong recommendation to start anti-resorptive therapy. And if you're above 10, it's a strong recommendation to consider osteoanabolic treatment. So in that sense, I hope it will help clinicians to really not only decide who is to treat, but also to consider which type of therapy that we have available should be considered.
I mean, I really look forward, hopefully, to it being more widely available. The fact that you include falls in it, I think is very important.
Yes.
And I think the fact that it's a 3-year prediction is also, it's useful for me as a doctor, but I think it's quite relevant for some patients because, as you quite correctly say, if you're seeing patients in their 70s and 80s and you give them a 10-year prediction, a lot of patients will say, well, you know, I can't see 10 years ahead, but 3 years is very relevant.
Yeah.
So, yeah.
I'm glad you like that. And your comment on falls leads me to make one more comment about our algorithm. So amongst these 33 risk factors, we have quite a number that are related not to the bone aspect, but more to the fall propensity aspect. So, of course, falls in the last year, none, 1 or more. So we have 3 levels there. But then also diseases, I mentioned Parkinson before, that enhance the risk for falling. So we have actually maybe 7 or 8 risk factors in that category. And I mentioned earlier that for each patient you pick only the strongest and the second strongest.
Yeah.
So if you have several within the fall category, you're only allowed to pick one.
One of those, yes.
One
So
of those.
if you tick the Parkinson's box, you're not
Yes.
allowed to tick the osteoarthritis box as well or something. You have to tick a box in a different category,
Exactly.
such as taking steroids or family history.
Exactly,
Oh,
exactly.
yeah, that's
Because we really don't want to overestimate if there are 2 risk factors that are not truly independent in
Yeah,
the assessment of risk.
A big sort of topic of conversation in the world right now is artificial intelligence and how it's going to change the world around us. I've noticed at this ECTS some artificial intelligence work has started to come through, and some of the presenters have been talking about the potential role for AI in improving fracture risk assessments and treatment assignments for patients. Do you think that's something that might work in the bone world?
Absolutely, absolutely. So a big part of my research in the past 8 years has been on developing AI methods, particularly for imaging. And to just give you an example, in the FRAX algorithm and our algorithm, we currently are basing the image information on the results from the DEXA device. But there are other methods out there. And for example, we did a study, reported it at ASBMR, that just taking a DEXA image and doing AI on the very same DEXA images already improves things. So, but then you have X-rays, you have other imaging modalities like CT, etc. And I think one great option is to widen the availability of diagnostic tests by incorporating equivalent ways across all of these different imaging modalities. And in that setting, AI is a terrific tool to establish, let's say, what is a risk threshold equivalent to minus 2.5 on a CT of whatever you're measuring. Yeah? So many options in there. And then The second way would be to incorporate this and do the modeling of the entire algorithm using AI, which also will lead to new ways. And in a third way, the way of interacting with the patient, think of ChatGPT and other tools, could be totally different. Yeah?
The ECTS and especially the ECTS Academy are really good at trying to bring through young scientists, people building their careers. I guess there might be a lot here who might be looking at AI and thinking, well, this is clearly an important future for our field. How would they get into it? Like, what kind of training and expertise should young people pick up if they want to get into AI?
That's a very, very good question. I'm extremely glad that you mentioned the Academy. I was fortunate to initiate 10 years ago the founding of the ECTS Academy, and just yesterday we celebrated 10 years. And it was so great that this really caught on. And one of the great things of the Academy is the interdisciplinary nature. Yeah? There are people that have a surgical background, an internal medicine background, etc., and everything. And to come back to your question, that is the challenge, because you need to figure out ways how computer people and medical people develop some common language to understand what AI can do and what it not can do. My whole scientific life, I've been sort of in between the technology side and the application side in medicine. And yes, it is very difficult for each side. The technology side has great ideas, but doesn't know what are the main problems that need to be resolved. And on the medical side, you can say this much better, but you know what you need, but you may not be aware of the latest, greatest technologies. So we are always in the middle as medical physicists to sort of bring this about. And then training needs to go along those lines, bring those people together so they understand what the tools can do.
It sounds like you had a really interesting career. How did you go from sort of physics into osteoporosis?
Very good question. So I did a plain physics study. I did my diploma in Hamburg, Germany, where I still live. And then my supervisor asked me, okay, are you interested in doing your doctorate? I said yes, and so he said, okay, here are a couple options. One was a medical application of synchrotron radiation, first time ever developed just in Stanford. And I said, that sounds exciting, and he was excited. So I got into a medical application that was coronary angiography using synchrotron radiation. And so that got me into medicine. And then I wanted to do a postdoc in America, in the US. So I checked out sites, 50 sites, long story. In the end, I worked with Harry Genand in San Francisco. I worked there for 7 years total, and he was a great mentor. So I'm really very thankful that he got me on the route to assess bone, to assess osteoporosis, fracture risk. He unfortunately passed away a few years ago, but he was a terrific mentor, and we're trying to live up to the things that he sort of trained us in. Yeah.
That's really wonderful. Thank you for sharing your time with us today, and thank you for starting up the ECTS Academy. As the regular listeners will know, it was through the ECTS Academy that we arranged recording the podcast from ETS Live, and they've been great supporters, and we've interviewed some members over the last couple of years. So thank you very much.
Well, it was a wonderful experience. Thank you for putting together this podcast. I mean, not this very one, but the series. And I'm really excited about this, and hopefully we can work together. Also at the International Federation of Musculoskeletal Research Societies, I think we would like to enhance the exposure worldwide. That's hopefully a bright future.
We would very much appreciate that. That's great. And you've definitely done well enough to get one of the BoneUP mugs.
Okay, this made my day.
Thank you, Klaus.
Thank you very much.
Thank you very much. Bye-bye.
Listeners, thank you for tuning in to episode 1 of BoneUP Live ECTS 2025. We hope you enjoyed it.
Watch out for episode 2, which will be along soon. Bye now.